Good evening, everybody. Welcome to this evening episode of Pursue 6, which is liver pathology. And today we have Pursue 6D. And we are streaming live from RML New Delhi via Kolkata. And today we have a very special person, Dr. ARVIND AHUJA, who's an expert in liver pathology, one of the national experts, and he is an MD from PGI Chandigarh, professor and head of histopathology lab in the Department of Pathology, Atal Bihari Vajpayee Institute of Medical Sciences, Dr. RML Hospital, New Delhi. He has more than 20 years of experience and more than 120 publications in international and national journal, and he will be talking on inflammatory and infectious liver diseases. Before I ask Dr. Ahuja to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Professor Ahuja, sir, please share your screen and start your presentation. Just press present now from the right side and your entire screen, and then you click in the center of the screen and share. Yeah, I can see your screen coming. Yeah, that's it. Please make it full screen. Now it's gone again. Please share your screen, sir. It's just gone.
Yeah,
Yeah,
sure.
yeah, it is there right now. Yes, you can just make it full screen. Great.
Oh, it's fine.
Fine. Thank you, sir. Please start.
Yeah, thank you, sir, for kind introduction and having me here to speak about something about liver diseases. And my topic is inflammatory and infectious liver diseases. Basically, inflammation of the liver is hepatitis. So any pathology which infects liver leads to hepatitis. Hepatitis can be due to infectious diseases, it could be due to metabolic diseases, it could be due to fatty liver disease, biliary pathology, and many other things. Today, we will be concentrating on the infectious causes of hepatitis, basically. Before I start, my sincere gratitude to my uh, teachers, Professor Ashim Das from PGIMER Chandigarh, and Dr. Professor Siddharth Gupta, who is a retired professor from AIMS New Delhi. These two have taught me the ABCD of liver biopsy. Now, this is my approach how I deal with a liver biopsy. Basically, whenever we get a liver biopsy, we should know what are the indications of the liver biopsy, especially when we are dealing with the infectious causes. You should know why clinicians are sending you liver biopsy. They want to know the staging as well as the activity of the disease. We want to know if there is any pyrexia of unknown origin, or there are enzymes which are elevated which cannot be explained. So there are various causes in which liver biopsy is indicated. Now, the second important point is importance of clinical, serological, biochemical, and radiological details, because our diagnosis is most of the time based on serology and radiological details. So you should know the background, why the biopsy has been done, what is the serology report, what are the biochemical details, and as well as which pattern of disease we are looking in the microscope, whether it is a acute hepatitis pattern or it is a chronic hepatitis pattern, whether it is a biliary pathology or it is a fatty liver disease or metabolic disease, and many other diseases like DILI, which is a drug-induced liver injury. So you have to see various patterns and you organize them to reach a final diagnosis. Then there are differential diagnosis based on the patterns. Whether it is an acute hepatitis pattern, the differentials will be different. And if we are getting a biliary pathology pattern, then the differential diagnosis will be different. Now, a complete report should accompany with it activity and chronicity scoring. And we all know there are most importantly two scores: histological activity index and its stage, whereas and as well as meta staging. We'll see later on. when we are going with diseases. And I'll show you slide seminar of common diseases which I have encountered in my practice. So whenever we see a liver biopsy, we should first start look at the low power. At the low power, we see the adequacy, whether biopsy is adequate or not. For adequate biopsy, you should see at least 6 to 8 portal tract. Then we see go for the overall architecture of the liver, whether the architecture is maintained or there is a distortion of the lobular architecture, there is a bridging fibrosis or cirrhosis. You have to see at low power. Then we have to assess whether the pathology is involving which part of the liver, whether it is involving the portal tract or it is predominantly in the lobules, or it is basically a sinusoidal or vascular pathology. Then we see for the fatty change whether fat is present or not. If there is a fatty steatosis, then what is the pattern of distribution of steatosis? Then other point is we look for portal tracts, presence of inflammation is there or not, and it is whether there is interface hepatitis or only portal inflammation. And we also look for lobules, whether there is a parenchymal inflammation or lobular inflammation is present or not. The other point, second, the other important point is to look for cholestasis and deposition of pigments in the sinusoids or in the hepatocytes. We should also look for sinusoidal dilatation and vascular pathology, and as well it is there a space acquiring lesion in the liver or not. After that, we shift to the high power examination of the liver biopsy, in which we do the confirmation of the pathological features which we have seen in the low power. We look we look into the portal tract and see whether bile duct, hepatic arteries, and portal veins are there or not. Adequate number of the portal tract, adequate number of ducts are present or not in almost all of the portal tracts. Then we move to the parenchyma and see what are the changes in the hepatocytes, hepatic veins, sinusoids, and then we can also use different stains to look and see whether to confirm our findings which are there on H&E stain. Now, pattern recognition is very important. There are various patterns which we see in our daily practice. These are the most important patterns which are encountered, like acute hepatitis pattern, chronic hepatitis, fatty liver disease, biliary pathology, vascular pathology, and you can see a metabolic liver disease or congenital liver disease, and you have to see the architecture and fibrosis in the liver biopsy. Now, today we are going to see predominantly acute hepatitis and chronic hepatitis pattern, because we are going to see infection-related hepatitis and inflammation of the liver. As we all know, viral hepatitis is the most common cause of hepatitis, and these are the list of hepatotropic viruses: hepatitis A, B, C, D, and E. All are RNA virus except hepatitis B, which is a DNA virus. And hepatitis A and hepatitis E are most important and most common cause of acute hepatitis, whereas hepatitis B and C are most common cause of chronic hepatitis. Hepatitis A is basically RNA virus, and it causes diseases by fecal-oral transmission, and it is mainly responsible for acute hepatitis, especially in India. And hepatitis B is common all over the world, and it basically leads to chronic hepatitis, and it is also associated with cirrhosis and hepatocellular carcinoma, we all know. And HCV is rising, and it is a chronic disease, develops in 60 to 80% of the persons, and it is mainly through the perinatal, and sexual spread is less common. It is mainly through the parental transmission. And hepatitis B is also a RNA virus, and it occurs in association with hepatitis B, and HBV worsens the clinical severity of the HBV infection. And then last, hepatitis E, basically it is a sporadic periodic cause, and it accounts for predominantly fecal route, and it is one of the important causes of acute hepatitis, especially in pregnant women. Then there are other viruses also which can infect liver and cause hepatitis. But these viruses are basically systemic viruses, but along with other organs, they can also infect liver. Most common are Epstein-Barr virus, herpes simplex virus, cytomegalovirus, yellow fever, and HIV. Coming to the acute viral hepatitis. Basically, it is characterized by injury to the hepatocytes and is identified clinically by a marked increase in aminotransferase activity. Here, AST and ALT will be markedly raised, whereas bilirubin or alkaline phosphatase will be slightly raised. Whereas cholestatic hepatitis is also a clinical variant of acute viral hepatitis in which biliary dysfunction predominates, and it is characterized by elevation of alkaline phosphatase as well as bilirubin, while AST and ALT are less raised as compared to the alkaline phosphatase and bilirubin. Coming to the microscopic features of acute viral hepatitis, the inflammation is predominantly lobular, and you can see lobular regeneration in the form of binucleated or multinucleated hepatocytes, and there is disarray, there is lobular inflammation, sinusoidal Kupffer cell prominence, there is ballooning degeneration of the hepatocytes, there are apoprotic bodies or acidophilic bodies, and there are mononuclear inflammatory cells along with occasional eosinophils or neutrophils present predominantly in the lobules. You can find canaliculaar cholestasis, especially in the perivenular region when you are dealing with the cholestatic variant, and you can also see hepatocyte dropout, confluent or multi-acinar necrosis can also be there, and total inflammation is present in many of the cases similar to the chronic hepatitis, and you can also see multinucleated hepatocytes or giant cells, and in some cases there is ductular reaction also. This is a low power view of a biopsy. As we can see, the biopsy looks quite busy at the low power, and we can see there is lobular disarray. The hepatocytes are quite busy, and there is inflammation which is present in the lobules as well as in the sinusoids. Coming to the slightly higher power, as we can see, there is lots of lobular activity with sinusoidal Kupffer cell prominence. This is a venule with perivenular confluent hepatic necrosis is there, and the hepatocytes are showing some ballooning. Another focus showing confluent hepatic necrosis. Confluent means there are multiple hepatocytes which are showing necrosis, and the adjoining hepatocytes are showing ballooning. Another hyper view which are showing this dilated and ballooned hepatocytes with multinucleation, which indicates that there is some degenerative activity going on. There is degeneration of the hepatocytes with clearing of the cytoplasm and pumping. Another high power view showing ballooning degeneration and necrotic hepatocytes, degenerating hepatocytes, lots of inflammation in the sinusoids as well as in the lobules with prominence of Kupffer cells in between. This is a necrotic hepatocytes, is also known as a councilman body or acidophilic body, and here also you can see lots of mononuclear cells in the sinusoids as well as in the lobules which are present here.
Dr. AHUJA, if you can just press
Yeah.
that hide so that that pop-up can just go away.
Right, okay.
Yes, thank you so much. Yeah.
Okay. So coming to the portal tracts can also show portal inflammation. You can also find interface activity when there is spillage of the mononuclear cells into the adjoining hepatocytes, which is known as interface activity. So you can find portal inflammation as well as interface activity. in the acute hepatitis also you can find some neutrophils or eosinophils also. This is a slide showing multinucleated or giant hepatocytes. Multinucleation, which indicates that there is necrosis as well as regeneration of the hepatocytes, and there is some cholestasis also here. You can see here also there is cholestasis, which is seen in cholestatic variant of acute hepatitis, and you can see cholestatic rosettes also. Rosettes are basically gland-like formation of the hepatocytes with central lumen. Here we can see lumen is filled with a bile plug, and here we can see canalicular cholestasis also. So all the findings are consistent with the diagnosis of acute hepatitis. We are not sure whether this acute hepatitis is due to hepatitis A or due to hepatitis E, or it is due to drugs or due to Wilson disease or any other causes. So serology and clinical correlation is must. Once clinical will tell you that yes, patient is a hepatitis A positive, then only you can say that this is acute viral hepatitis due to hepatitis A. So this is the evolution of the acute hepatitis. It regresses most of the time, and you can see residual hepatitis. The biopsy is delayed, and there are certain soft points which can help to reach a diagnosis, like hepatitis A associated acute viral hepatitis. The portal and periportal pattern of inflammation, or which is known as interface hepatitis, is more common, and predominant cells in the portal cracks are plasma cells, and cholestatic hepatitis, especially in the perivenular cholestasis, is commonly seen in hepatitis A related acute viral hepatitis. Another common cause of acute viral hepatitis, especially in India, is hepatitis C, and it is also similarly two types: classical type, which we have seen all the features can be there, and cholestatic type, in which sometimes you can see neutrophils as well as cholangitis along with lots of cholestasis. This is a special variant of hepatitis E, and diagnosis can only be reached when you know the serology. Serology is most important. So this is a differential diagnosis of acute hepatitis. Whenever you suspect acute hepatitis, there should be anti-IgM, anti-HIV antibody should be there. And the acute hepatitis is hepatitis B related, then you will find serology with the HBs antigen along with coexisting IgM anti-HBC, which is a acute marker. Then acute hepatitis C infection, then you should have an anti-HCV antibody in serology. And acute infection with hepatitis D, you can find a delta antigen in the serum. HBV is most of the time coexist with almost always coexist with hepatitis B co-infection, and because delta antigen requires the metabolic capabilities of hepatitis B virus to survive, then hepatitis for diagnosis hepatitis E infection, anti-HCV antibody should be there in blood. Now coming to the chronic viral hepatitis. Chronic viral hepatitis is a syndrome of persisting hepatotropic viral infection, usually associated with chronic inflammation, hepatocyte injury, and progressive fibrosis. Infection of more than 6 months is considered evidence that the spontaneous resolution of infection is unlikely, and the hepatitis has progressed to chronicity. So it is a chronic hepatitis when the infection persists for more than 6 months. On microscopy, predominantly activity is at the portal tracts. So you find predominantly portal tract inflammation. There is interface hepatitis, and similar to the acute viral hepatitis, you can find the lobular eosinophilic bodies or councilman bodies. Then there is mononuclear inflammatory cells in the lobules as well as in the portal tract. Total based lymphoid aggregates can also be there if it is mostly when it is related to hepatitis C. You can also find the lymphoid follicle formation. And whenever there is portal inflammation and fibrosis, there is bile ductular proliferation, and there is progressive fibrosis and eventually cirrhosis in chronic hepatitis. So chronic viral hepatitis, here you can see this is a low power view. At this power, we can observe that there is lots of activity in the portal tract. There is a lymphoid aggregate, as well as there is, in the hepatocytes are showing acinar disarray, in lobular disarray in the form of macrovascular steatosis, as well as some lobular inflammation. Another low power view showing steatosis, which is predominantly macrovascular. The portal tracts, even at this low power, we can see there is some lymphoid aggregates and mononuclear cells are there in the portal tracts. High power view, you can see that this is a portal tract which is showing some lymphoid aggregates. This is a bile duct, and this is a limiting plate. Here, the portal inflammation is restricted to the portal tracts. There is no significant interface activity, and the hepatocytes adjoining the portal tracts are showing ballooning degeneration. Other portal tracts were showing inflammation along with interface activity. There is spillage of the mononuclear cells into the adjoining hepatocytes. This is a high power view of the same, showing spillage of the lymphocytes into the adjoining hepatocytes, and there is ballooning of the hepatocytes with the rarefaction of the cytoplasm. This is another one focus showing spotty necrosis. Here there is one of the hepatocytes has degenerated with lymphomononuclear cells here, and some hepatocytes are showing mitosis, which indicates some degenerative activity side by side. Similar hyperview showing lobular inflammation, spotty necrosis, and these are the macrovascular steatosis with ballooning of the hepatocytes. This is a Mason's trichome stain to see whether the fibrosis is portal based or it is periportal, or there is a bridging fibrosis. At this power, we can see that the fibrosis is predominantly restricted to the portal tracts. So it is a portal fibrosis, and the reticulin stain also shows portal fibrosis, and we can see the hepatocytes, lobules or hepatocytes are showing predominantly single cell pattern. There is not much regenerative activity going on. So these are not the slides of similar case, but this is to show you that Mason's trichome stain beautifully highlights the portal fibrosis, as well as you can find periportal extension of the fibrosis, and this is another small portal tract. So there is a portal bridging fibrosis also, thin septa being formed here. So this was a chronic hepatitis, and you should know the serology before jumping to the diagnosis of chronic viral hepatitis, whether it is a serology was positive for hepatitis B or C or some other disease or autoimmune markers. So along with histology, you have to include activity and chronicity scoring so that it will help the clinicians treat the patient. So we have a most important activity score is ISHAC modification for hepatic activity index, which is basically has four components: periportal or periseptal interface hepatitis, confluent necrosis, focal lytic necrosis, evocosis or focal inflammation, and portal inflammation. So basically, confluent necrosis has 0 to 6 score, whereas other three have a 0 to 4 score. The one thing I want to highlight is that the periportal inflammation, when the interface activity is less than 50% of the circumference of the portal tract, and it is score is 3. When the activity is severe and it is continuous more than 50% of the around the portal tract, it is score 4. So there are various scores for confluent necrosis 0 to 6, For spotty necrosis 0 to 4, and for total inflammation 0 to 4. So you have to give a total score which will be divided by 18. So total score is 18, and you have to score depending upon the findings which are there in the biopsy. Now we have a Ishak staging also, which is for fibrosis. This is enumerated at 0 to 6. 0 is no fibrosis. 1 is the fibrous extension of the some portal tracts, whereas 2 is fibrous expansion of the portal tracts. 3 is fibrous expansion of the most portal tract along with occasional protoportal bridging fibrosis. And score 4 is fibrous expansion of the portal areas with marked protoportal and protocentral bridging. Marked bridging with occasional nodule is incomplete cirrhosis, score is 5, and cirrhosis is a score 6. Similarly, we have a Metavir score system for fibrosis. This is preferred by most of the clinicians because this score corroborates with the radiological score, which is also from 0 to 4. F0 when there is no fibrosis. F1 the fibrosis exists with expansion of the portal zones. Basically, is the portal fibrosis. F2 when there is a portal fibrosis and occasional bridging. F3 is fibrosis with expansion of most of the portal tracts, making bridging and occasional nodules. And F4 is presence of cirrhosis. There are certain soft points which can help you to reach a particular diagnosis. But I'm repeating again and again, serology is most important. You need a serology because before saying that this is chronic hepatitis related to hepatitis C or B and blah blah. So for hepatitis C, uh, we see prominent lymphoid aggregates or lymphoid follicles with terminal centers in the portal tract, and they can also show prominent bile duct damage, and hepatitis C can also show steatosis, which is mostly mixed micro and macrovesicular, and it is mostly related to genotype 3, and you can also find high hepatic iron stores. So, in this particular case, final diagnosis based on the serology, which was positive for HCV, we made a diagnosis of chronic hepatitis, HCV related, and you have to give a activity index scoring as well as you have to stage. Now, for hepatitis B, the tools which can help you to reach a diagnosis are that it shows usually ground glass hepatocytes, and can also find sometimes sanded nuclear inclusions, which are basically a core material, and ground glass hepatocytes are basically endoplasmic reticulum, which is filled with hepatitis B surface antigen. So this is a picture of ground glass hepatocytes. You can see nucleus is pushed at the periphery, and there is pale appearing hepatocytes with some ballooning, which is due to hepatitis B surface antigen in filling the endoplasmic reticulum. There's a differential diagnosis of ground glass hepatocytes because you have to confirm that these ground glass hepatocytes are due to hepatitis B. So you have to do ISC for hepatitis B surface antigen, or you can do Orsin also. So when you see there is a differential diagnosis of ground glass hepatocytes, it could be due to glycogen. So we have to do PAS and PS, which is PS positive and diastase sensitive. It could be due to cyanamide. Type 4 glycogen storage diseases, Lafora disease can also show, which is PS positive but diastase resistant, and fibrinogen can also present as a ground glass. So you have to do a fibrinogen stain, and uremia can also show ground glass hepatocytes. So there's a whole differential diagnosis. Certain drugs which are used, especially in transplant recipients, can also cause a ground glass hepatocytes. So this is a Orsin stain which highlights hepatitis B surface antigen in the ground glass hepatocytes. It gives a brownish granules, some brownish granules can be seen. Then this is a ISC for hepatitis B surface antigen, which shows a strong cytoplasmic positivity here, and core antigen, which can also show cytoplasmic as well as nuclear positivity. If you find this, then you are sure that you are dealing with hepatitis B. There is another distinct variant of hepatitis B, which is known as fibrosing cholestatic hepatitis. Basically, in FCH, there is fibrous expansion of the portal tracts, and there is extensive ductular reaction, often with ductular cholestasis, and there is also marked bilirubinostasis in the hepatocytes. This is a photograph showing you marked portal fibrosis with ductular proliferation. Lots of ductules are proliferating, and there is a case of fibrosing cholestatic hepatitis. This is a variant of hepatitis B. Then coming to the non-hepatotropic viruses, EBV usually causes a systemic disease, but it can also infect the liver. Whenever it affects the liver, there is a diffuse sinusoidal lymphocytic infiltration, which is in the form of Indian file, or you can say a string of bead pattern. Lymphocytes are standing in the line inside the sinusoids. You can find a portal inflammation which shows predominantly lymphocytes, similar to the other viral hepatitis. Portal inflammation, periportal spillage or interface activity, as well as lobular inflammation, can also be seen in the hepatitis B, hepatitis EBV related hepatitis. Sorry. So this is a photograph from Maxine in which you can see there is lots of lobular inflammation, and their sinusoids are engorged with mononuclear cells along with few neutrophils here. Another photograph which is showing lobular inflammation in the form of lymphoid aggregates, and you can see the sinusoids which are showing Indian file pattern of mononuclear cells that are appreciated in this high power. The sinusoids are filled with mononuclear cells forming an Indian file pattern or leaf pattern. So this is one of the important features of EBV hepatitis. But again, you have to confirm it by serology, because Indian file pattern of infiltration by the mononuclear cells can also be seen with D, which is a drug-induced liver injury, especially with phenytoin. And you can also find this pattern with NHL infiltrating the liver, and sometimes, rarely, it can also be seen with hepatitis C. So, serology is must for diagnosing EBV hepatitis. Coming to this case, this was a 18-year-old female. She developed sudden massive rise in transaminase 1 week post-transplant, which was done for PSC and AIH overlap, and AST suddenly jumped from 40 to 1000 in a week. The cause was not known. Hepatic artery was patent on imaging, therefore, patient underwent biopsy. This is a biopsy in which you can see there is confluent hepatic necrosis with multi-acinar necrosis is there, and this is a portal tract, and these are the preserved hepatocytes. High power view hepatocytes adjoining the necrotic hepatocytes are showing these intranuclear inclusion. As you can see, the chromatin is pushed at the periphery, and the center part of the nucleus is occupied by inclusions. And then ISC was done for HCV, herpes simplex virus. It was showing strong cytoplasmic as well as nuclear positivity. So it was a HCV related hepatitis. Similarly, you can find cytomegalovirus inclusions in certain cases, which is due to CMV hepatitis. As you can see here, there is owl-eye appearance of the inclusion, intranuclear inclusion with perinuclear clearing here. This is a diagnostic of CMV hepatitis, which will be confirmed by ISC. Another case of infection related hepatitis. It is a 19-year-old male. It was a very young, enthusiastic boy who presented with pyrexia of unknown origin. Patient was having a low-grade fever since 3 months and was not responding to any of the antibiotics, and there was on blood examination there was transaminases were raised, and on imaging they find few small lesions in the liver. So they were suspecting probably it is a lymphoma or tuberculosis, or there were other differential diagnoses also. So the patient underwent biopsy. This is a low power view of the biopsy. As we can see, there is lobular disarray, and this is the area showing these well defined nodules. Another slightly high power view shows that these are basically epithelioid cell granulomas, these Langhans type of giant cells surrounding lymphocytic infiltrate. This is a high power view to better appreciate these epithelioid cell granulomas with Langhans and foreign body type of giant cells surrounding fibrosis. This was especially in the perivenular area, and reticulin stain, it was retic poor. So, however, if you are lucky, you can find a necrotizing granuloma, uh, possibility for acid fast bacilli when you do AF Zanzil Nelson stain. So it was a case of granulomatous hepatitis, and it was suggestive of tuberculosis. Although the AFP was not positive, patient was given a trial of ATP, and there was patient improved after that. So tuberculosis basically accounts for 1% of all tubercular infection. Liver tuberculosis, liver biopsy and culture for mycobacterium is considered the most specific diagnostic test for hepatic tuberculosis. Patients with hepatic tuberculosis are usually present with pyrexia of unknown origin with deranged LFT, as in our case. So whenever we see granulomas in liver biopsy, there is a long list of diagnoses, but the predominant ones, especially in India, are first is tuberculosis, and second is sarcoidosis. Then you can find granuloma in primary biliary cholangitis. You can also find granulomas in certain drug-induced liver injuries, and there are other long list of infectious causes which can show granuloma. Tubercular granulomas are not fixed; they can be present anywhere in the biopsy. Whereas sarcoid granuloma, they are usually numerous, discrete, non-caseating, and they are predominantly peripodally distributed. You can find asteroid bodies or Stroman bodies, and primary biliary cholangitis, the granuloma is predominantly total case because there is an injury to the bile duct and there is granuloma formation. P can also show, drugs can also show granulomas which are predominantly in the lobules. You can find granulomas in the other locations also. So there is a long list of effective causes of hepatic granulomas. The most common we have seen is Mycobacterium tuberculosis or MAI in the cases of immunocompromised patients, Mycobacterium avium intracellularly. And it could be due to Brucella echinacea, which shows a fibrin ring surrounding fibrin ring granulomas. Then you can find small granulomas in this area also. The most common fungal infection in which granulomas can be seen is histoplasma, and helminths can also show granulomas like cystosoma, or you can find granulomas in case of leishmania, and some very rarely in hepatitis C infection also. Now coming to the fungal infections involving the infiltrating the hepatocytes. This was a case which we got 3-4 years back. It was a 50-year-old male. Patient was a renal transplant recipient, and patient had a fever with raised AST and ALT. they had no clue why there's fever, so they underwent liver biopsy because there was no other choice to know. And this is a hyper view. The biopsy was largely unremarkable. There was just cholestasis here and there, and there was when we saw it in the hyper view. This is a basically oil immersion view to basically highlight that sinusoids. These are the Kupffer cells inside the sinusoids, and you can see here the nucleus of the Kupffer cells is pushed at the periphery, and you can see these organisms perinuclear halo. Here also one of the Kupffer cells showing these organisms. Another field showing these organisms with perinuclear halo or capsule inside the Kupffer cells with the nucleus pushed at the periphery. These are the nucleus of the hepatocytes, and you can see there's some cholestasis. So on PS, it highlighted this organism. So it was basically a histoplasma, and patient was treated thereafter and with antifungal, and patient became all right. So you should look for fungal infection whenever there is a history of immunosuppression, and you have to concentrate predominantly in the Kupffer cells because it is a part of reticuloendothelial system. So most of the organisms will be found in the Kupffer cells. This is a picture from the Maxwin in which you can see Cryptococcus, which is showing budding yeast also, spores of Cryptococcus inside the sinusoids and inside the Kupffer cells. Now you can see find protozoal infections are also very commonly infect liver, especially certain protozoal infections like in this case, this is a photograph showing hepatocytes with this is a abscess, neutrophilic abscess, and these are the hepatocytes surrounding the abscess. And when you move slightly high power, you can find these that there are these round organisms. Basically, these are the trophozoites. It can be better appreciated by PA stain. So these are the trophozoites of amoeba which are present here. So it is a amoebic liver abscess, and the patient was alcoholic. Then you can find infection by malaria also, in which to identify malaria, you have to concentrate on the Kupffer cells, which can show malaria pigment as well as RBCs. On the oil immersion, you can see some dot like malaria type forms of malaria. So this was a case of malaria inside the hepatocytes, liver, infecting the liver. Leishmaniasis antibodies can also be seen. Usually the patient is not biopsies, but sometimes incidentally biopsy is done and you can find these antibodies which are usually present in the Kupffer cells, can also be present in the hepatocytes, and these are this can be diagnosed on liver biopsy incidentally also. Now coming to the helminths. Helminths can also infect liver like other infectious diseases. This was a case which was shared by a colleague. It was a 1.5-year-old female, 1.5-year-old female, which presented with fever for 2 months. Fever was high grade and it was associated with abdominal distension, loose stools, and on her abdominal examination, the patient had a hepatosplenomegaly. These are the investigations which were done. Patient had a severe anemia. PLC was 26,700, and we can see here absolute eosinophilic count was 8,800. That is 33% eosinophils were there. ESR was also slightly raised, and alkaline phosphatase was 411, and LDH was slightly raised. So this patient had a eosinophilia with absolute eosinophil count more than 8800. So there was a suspicion of infectious diseases, uh, especially parasites, and this is a liver biopsy. As we can see, there are lots of organisms here which are present with areas of necrosis and intervening fibrosis. These organisms are showing double layer wall with some sun ray like appearance, and there is central necrosis with foreign body giant cells are also there. This is a hyper view to better appreciate that these have a double layer with some septations in the wall and surrounding giant cell reaction. There was these granulomas with central necrosis, and we can see there were many eosinophils surrounding these granulomas, so it was eliciting a granulomatous response. So this was a case of granulomatous hepatitis due to Filaria hepatica. Basically, this is a parasite nematode causing hepatic capillariasis in the rodents. Humans are accidental hosts, and it was first discovered by Bancroft. There are around 70 cases reported, and there are 3 cases from India also, especially in the developing countries vulnerable to the low socioeconomic background. So, similar to the Capillaris hepatica, this is another organism which is commonly seen in the eastern countries, but rarely can be seen in India also. It has a single layer of wall here, and this is basically a schistosomiasis infecting the liver. Sometimes uh, or often hydrated cyst can also be seen in the liver. This is a lobar view showing that there is a one scolex of the hydrated, which is seen here with surrounding inflammatory response. These are the hepatocytes, and this is a hyper view showing lamellated membranes and scolex of hydrated. So hydrated can also be found in the liver. So these were the common infectious causes of liver diseases. My take home message will be liver biopsy remains the gold standard for evaluation of infection related liver diseases. Clinical, serological, biochemical, and radiological correlation is must. You have to have a systematic approach, and pattern recognition is important to interpret the liver biopsy and to reach a correct diagnosis. And whenever you diagnose viral hepatitis, chronic viral hepatitis, you should have a grading, staging, and scoring also, which are important component of the liver biopsy report. Thank you very much. Happy Diwali to all of you.
Thank you, Dr. Ahuja. Happy Diwali to you as well and your family. Excellent
Thank,
presentation. And you presented like a veteran. Basically, such a large topic. You have really concised it and put it exactly what is required for the residents, postgraduates, as well as for junior consultants. And it was represented pictorially so that, no theory, you can see the things, you can understand what is balloon degeneration, what is eosinophilic body, everything. So wonderfully done. Excellent. Thank you so much. Let me
I
see if
have
there are any.
basically I have included pictures so that there is not much theory here. Basically, it is a practical approach how to deal with the infectious hepatitis. So I
Absolutely
thought it
right.
will be
Absolutely.
helpful.
Yeah, yeah, absolutely right. The theory is too long and too boring, and everybody
Yeah,
can read that in the textbooks. It
yeah,
is what the
that is there.
clinicians and the experts tell you exactly this is what it is. If this is hepatitis C, this is hydrated.
Yeah,
So important, and you have dealt with the entire spectrum, not only one segment, the bacterial, the chronic, the viral, the protozoal, the helminthic. Everything has
yeah.
been dealt very well. Thank you so much. And I don't think so. We are going to leave you like this. We know that you are very good in dermatology also. So once you start dermatology, we'll definitely catch you. You are a very good presenter, excellently presented. Thank you so much. God bless you. Thank you. Have a nice
Thank you,
Diwali.
sir.
Take care, everybody. Bye bye.
Okay, sir. Bye.
Bye. Thank you. Bye.
Thank you, sir.